just see my PowerPoint?
No, you're perfectly fine.
Okay.
I will manage it. Don't worry. Your beautiful face is not going to cover up any of your slides.
Okay, perfect.
What's up, everybody? I'm so excited about today's speaker. I've been waiting months for this amazing presentation to have this amazing woman, chiropractor, educator, sheer genius, and absolutely funny presenter here today to talk to you. So if you don't know who Dr. Petrocco-Napuli is, shame on you, because she's like everywhere. You may have seen her on all the advertising for the ACA Women's Symposium that is coming up. She is an educator at Logan University. If you're in Florida, you probably saw her at FCA National on the Amazing Sex Panel. And if you don't know what that's all about, ask me about it and I'll tell you. It's very entertaining, very educational. She completed her chiropractic degree from New York Chiropractic College, did her postdoctoral fellowship in technique at New York Chiropractic College, who just recently changed their name and I can never remember it. So I'm working on it. So if y'all are all like, that's not what it's called anymore, I know. But she has been focusing a lot on women's health. She is one of the leading experts on this topic, along with some other amazing women that she is friends with who thankfully introduced me to this beautiful soul. And I am so excited to have her present to you today. So, Dr. Chris, thank you so much for being here.
You're welcome. Thank you so much for having me. And I am so honored and so grateful to be with all of you today. And Christy, thank you so much for the wonderful introduction. I can't thank you enough. And I know this is a long time coming, so it's just wonderful to be with everybody. So I always start off every single lecture saying that the best ideas happen at 3 a.m. after we've had time together. And so my email address is up there for you. And before we get started, I just jot it down in case you have that 3 a.m. moment and you say, hey, Dr. Chris, I want some more information from you, or I want something that you've referenced, or I have a question about something that you've talked about. So as we get started today, we're going to really focus in on women and chronic pelvic pain and essentially chronic pain in general, because we know as chiropractic practitioners, we see women. We see a lot of women in our practice. And we know that those women tend to be the gateway of our practices, right? If we get them better, they tend to refer friends and family. They bring us their children. We know that women, and this is not anecdotally, we actually have evidence that shows us that women across the US are the ones that make the household healthcare choices. And those are for individuals within their household and even those that they care for outside of their household. And so, again, women really truly are the gateway to our practices. And I often say that regardless of when we went to chiropractic school or where we went to chiropractic school, no one really gave us a lot of focus or attention on the female patient, right? We learned in generality, and we may have learned some pieces and some components, but we didn't learn a lot on how to treat this population. And so it's really important for us as providers, especially in today's day and age, that we do have a good understanding about how the chronicity of pain, and even more specifically, the chronicity of pelvic pain, truly impacts our female patients. And so as we get started today, we are going to discuss, I mentioned this to you a little bit already, a little about chronic pain, the trends that we're seeing in our patients across the US, how this impacts our patients and how they're reporting pain to us. We're going to talk about some of the indicators that we see when we're taking a history and what some of those indicators can mean to us as practitioners. And ultimately, what it's going to mean for patient care and how our patients respond to care. And then finally, we're going to talk about some concepts related to patient-centered care and chronic pain. So I truly hope in the time that we have together that I do one of three things. And that is either give you something new to bring in back to practice this afternoon, really challenge you to think about something that maybe you haven't thought of before that you can apply to your female patients, or reinvigorate something that maybe you put away in your toolkit. We all do that in practice, right? We've done something for a long time, it works really well. And then all of a sudden one day we're like, why don't I use that anymore? That used to work really, really well. And so I hope that one of those three things really truly sparks you and fills your cup to go back into practice and really truly share this. I'm going to say something else that's really super important to me as a provider, and not just a provider, but also an educator and a speaker, that as practitioners, I often find that we forget about our staff and we forget to share this information with them, because truly when we're talking about the patient experience, right, it's our patient's experience with us, but then also those that work in our practice. And so sometimes when we go through these seminars and webinars, we don't often think outside of our doors as the provider, but really be truly thinking how those in your practice that support patient care can also benefit from some of this information. So I know some of you may just have gotten a visceral response when I put this up, right? But COVID's really changed a lot of things. And I've said to practitioners over and over again, the one thing that we do know is that with COVID, chronic pain patients still have chronic pain, right? It never went away, which is why a lot of us through the COVID timeframe and through the pandemic stayed and were able to treat patients, because our patients needed us for care, whether it was wellness or truly simply that they are chronic pain patients. And one of the pieces, if anything, that truly did happen with COVID is that some of our chronic pain patients actually got worse. And some individuals that never had chronic pain ended up with chronic pain now because of being at home and working maybe with poor ergonomics and a variety of other reasons which may have triggered it. And one of the big things that I always say to practitioners that we want to remember about our female patient is that our female patient's pain is multifactorial in nature, right? And so when we're thinking and we're taking our history, we really have to be cognizant about all of the contributing factors of pain. And when, I love this image, because when we look at this image and we see all of the different colors of the stained glass, they come together to form this beautiful pattern as the sun comes through it on the floor, right? And that shows us how all the pieces are working in synchrony. And that is also true with our female patients. When they're feeling optimal, when they're feeling really well, or their pain is decreasing, that means we're starting to see all of the pieces come together and they're functioning to create this beautiful synchrony for the patient. And so one of the things that we often see with our patients that are experiencing chronic pain is that they're missing that component of being identified. And what is that multifactorial pain that's really contributing, right? Is it musculoskeletal in combination with visceral? Is it visceral in combination with neurological? Is there also the component of maybe they've got a lot of stress and anxiety that's contributing to pain, right? Maybe they're not sleeping. Maybe they're not eating well, and what they're eating is contributing to their pain. So all of those factors really need to be dissected and really determined on the what. And I want to give you a little bit more of the so what, right? Because a lot of times I will give this lecture and practitioners will say, so what, Dr. Chris? Like, just because we treat a lot of women, why is this important? And I want to give you just a quick background before we jump into the chronicity of pelvic pain. And that is, a few years ago, the WHO, or the World Health Organization, made a statement which said, hey, practitioners, we really need to be better at treating women and children. And not only do we need to be better at treating women and children, we have to help them survive and thrive. And as practitioners, we're placing out a call to say, hey, you need to be better at that. And guess what happened shortly after the WHO? The World Federation on Chiropractic said the same thing. Hey, chiropractors, we need to be better at treating women and children. And something that we did forever in our profession is that we said women's health equals pregnancy, right? And I'm standing here shaking my head saying that's not true. Women's health is many other things besides pregnancy for a variety of different reasons, right? Many of our patients may not even choose the journey of pregnancy. And so we need to be cognizant that women's health embraces a lot of different topics. And again, that's where Christy kindly mentioned the ACA Women's Health Council, and that's where the ACA Women's Health Council emerged from, backing of some of these components relative to we need to be stronger, we need to be better as practitioners when it comes to treating women. Now, one of the big things, and I mentioned this to you, the World Federation on Chiropractic made their statement, and that's where we emerged from as far as the Women's Health Council. But one of the big things that I want to emphasize today is that I hope today also doesn't stop your journey of learning more about how to treat that multifactorial pain in women and how to really dissect the components that our female patients need, want, and deserve from us. The other component is when we're talking about treating women and we're talking about the components of care relative to this, we also have to train our patients to advocate for themselves, right? There are times when we see women who come to us and they've been all over and they'll tell you, doc, I've had this chronic widespread pain and I have been to everybody and I'm not getting better. And I don't know what else to do. And, some of the things that we see as practitioners when we're talking to them, we're also training them how to advocate. And that becomes really important by empowering them and giving them the knowledge they need to do so. I mentioned to you when we started off that we know many of our patients are female, right? When we look back at some of the evidence that supports what we say as providers, we know in fact that women are not more likely only to utilize us, but they're more likely to utilize chiropractic within the past 12 months. Okay, so when they're receiving care, we know that statistic is high for our female patients. The other big thing that I think is also important for us as providers is to talk about utilization. I always say it depends when we graduated from chiropractic school. Some of us heard it was 9%, then it, slowly bumped up, and then it was 12%. And now we're saying it's at about the 14% mark in general for utilization. Now, I've said to you, we know that women utilize chiropractic. There's no question. But what's the age range? And that also becomes very important to us as providers when we're thinking about this. We actually know that the typical female chiropractic patient is between the ages of 30 and 64 years old. Now, that doesn't mean that's the only bundle we should treat, right? But that's the primary percentage that we're seeing across the US. And this actually comes from the MBCE Practice Analysis 2020. So it's fairly new data for us as providers. And, one of the big things when we look across the entire profession, they say that age range is about 57% of what we're seeing in those demographics. Now, I want you to shift for a second, and I really, truly want you to be thinking about your oldest female patient that you see in practice and your youngest female patient that you see in practice. Because there are a lot of things that we know, not just behaviors that we see in women, and not only just looking at products that women use or how a female actually moves through maturation that set them up for long-term challenges, whether it's chronic pain, whether it's looking at them having dysmenorrhea, looking at age of menarche is also very, very important. And all of these factors actually truly do contribute when we're looking at some of our chronic pelvic pain patients. So really having an idea of what's on their plate, right, really dictates when we're looking at chronic pelvic pain. And one of the big things that I also think is important for us as providers is to not put an age on those patients for chronic pelvic pain, right? A lot of times when we think about conditions or disorders, we block them in an age range. And that can be helpful to us as providers, especially when we're ruling in and ruling things out. However, something is very different with us when we're looking at our female patients. Now, it's interesting because we know that the average age of menarche in the US is at approximately 12 years old. We also know that if a young female menstruates before the age of 12, it increases her likelihood of 50% for breast cancer and polycystic ovarian syndrome. But what we also know is that it impacts her age of menopause. Okay, so average age of menopause is 51. And so when we're looking at chronic pelvic pain, you really need to be thinking about some of your younger females that may have started menstruating early and how that can have impact on, are they in the chronic pelvic pain category? Are they primary dysmenorrhea? Are they secondary dysmenorrhea? And no one has diagnosed that because they're quote unquote young, right? So as a provider, those are some really important bases and ground things that we need to be thinking about clinically. I just mentioned to you earlier that a lot of times our patients will come to us and they'll say, Doc, I've been everywhere, right? How many times have we had a patient come to us and say, Doc, I have widespread pain. I have pain, from head to toe, and my labs are great. My x-rays are great. They've done every single test on me. They can't find anything wrong, right? And I think this image sums those patients up to us, especially when we're talking about our chronic pelvic pain patients and they come to us and they say, Doc, you know what? I've had multiple operations on my pelvis where they've done exploratory lap and they can't find anything. I've had a variety of tests. They tell me that there's nothing there, yet I experience pain, right? And so this image where this poor young girl has a rash all over her and they're saying, your labs are great. Everything is normal. You're the picture of health, right? But yet she's covered in a rash where she's uncomfortable. And those are the things that I think are important when we're talking about this, because it really can be a challenge for our female patients, not only to have the conversation with a new provider, but also get a diagnosis where they feel that they're heard. And not only that they're heard, but that they can be treated appropriately. And when we talk about the chronicity of pain, and we know this, regardless if it's pelvic pain, low back pain, cervical spine pain, whatever it is, we've all treated chronic pain patients, right? And we know that it can be a really vicious cycle for our patients. And, looking at that increased pain, if they're not sleeping well, sometimes when they have increased pain, there's other anxieties related to going to work and being able to function if they're not doing well. There can be a correlation with not coping with the pain well and trying to figure out how to decrease it and what that happy medium is. But I want to throw another piece when we look at the cycle. So when we're talking about the chronicity of pain in women and we're talking about pelvic pain, that sometimes that anxiety level can be much higher, especially if we're talking about individuals that have chronic pelvic pain and they're trying to conceive, or we're talking about chronic pelvic pain and we're talking about sexual health, and they have a lot of pain with intercourse, so that impacts relationships. There's a lot of stress there that can impact a female patient with us. The expectation for pregnancy and fertility can also be a real high anxiety component. And so again, we have to be just a little bit more sensitive and cognizant of this when we're talking about this group. The other thing that's very important to us when we're talking about chronic pelvic pain in females is that there are so many different categories of conditions that can overlap. And so remember when I said a few minutes ago, and I showed up the beautiful image of all of these stained glass colors, and they work together interchangeably when we're looking at somebody that's feeling well and everything's functioning. Well, now I'm showing you this other graph that shows you all of the different conditions that overlap in some of our female patients. And so when we're talking about multifactorial pain, we have to be thinking about these other things. So for instance, endometriosis, our patients may actually be experiencing vulvodynia. Sometimes it's embarrassing to talk about. Looking at TMJ or TMD, there's an association with some of that. Looking at IBS or irritable bowel syndrome and the combination of endometriosis and fibromyalgia or interstitial cystitis, right? So again, there's a lot of overlap. And so if you're not asking your patient questions relative to these pieces, then you could be missing something, and you could be missing a component of that multifactorial pain that these pelvic pain patients are reporting. And so,
Excuse
we
me,
actually,
Dr. Chris. I
yeah.
don't know what happened, but I'm not seeing your screen anymore. Can we
Uh-oh.
reshare?
Yep. I see. Um,
Click on your internet browser so it'll pop up that tab again.
okay, so it tells me to stop sharing. Should I stop sharing?
Stop sharing and then reshare.
Okay. I am so sorry.
I don't know if it's something that you did. My computer did something crazy, and then I just saw two of your beautiful face.
Okay. Okay, so I hit share.
Okay, now just pick up on your PowerPoint and you're good.
Can you see it now?
I can.
Oh, wonderful. Okay. So did you see this last slide?
I did right before my screen went funky and I saw your face.
Okay, wonderful. Okay, so we're right back where we were. So we actually know when we look at the literature that women are more likely to not only report musculoskeletal pain, but they're also more likely to tell us about widespread pain, abdominal pain, headaches, and pelvic pain. And so, interestingly enough, and I'm going to just jump on the widespread pain for just a second, because one of the things that the literature also tells us is that children and adolescents that report widespread pain or chronic pain in general are more likely to be young adults that report this. So it's really important in our history taking and gathering that when somebody is reporting chronic pain, pelvic pain, or chronic widespread pain, that we're asking not only when did this start, like we normally do, but we're actually doing a screening question that asks when you were an adolescent, did you have any of these types of pain or symptoms or diagnoses? And that again becomes really important to us as a provider. Um, when we look at women being taken seriously, this is very important for us as chiropractic practitioners. We actually know that it doesn't matter our gender as a provider, but we do know by looking at the research in the study that men are more likely to be treated quicker, faster, and more accurately than women. And so, going back over time to the stigma of emotion having impact on pain. Now we do know as providers that that can have impact, and whether you're male, female, regardless of gender. It doesn't matter what gender they identify with. That emotion can have impact. And so this is very important to us as providers to keep in the back of our mind. The other thing that we do know from the literature is that women are more likely to seek treatment for chronic pain. They're more likely to, believe it or not, receive inadequate care by all types of providers. There's excellent studies that talk about women that reported to the ER with similar symptoms to their male counterparts, which looked like chest pain or a heart attack, maybe even MI. And the men received care quicker and were provided with the appropriate tests faster than the females. And so they also identified in some of the studies that women were more likely to be prescribed sedatives first rather than pain medication when they were reporting it. So I do always ask that question in the female population as well. If they tell me that they have been to another provider, that they've been to the ER, what type of medication were you prescribed? Because that also will give you some insight on not only if they declared what they're taking, but will also give you some insight on maybe what they've taken in the past. Now, we do have to make sure that when we're talking to our patients, that we really are taking into account how they're attributing their pain. And we do know that women with chronic pain suffer much more and much longer than men before they receive adequate care. And, we would all say that this is very true with our chronic pelvic pain patients. When we think about those chronic pelvic pain patients, most of the time they have a very hard time getting a diagnosis. Endometriosis patients, on average, it takes 9 years for an official diagnosis for a female with endometriosis. And that is really, really challenging for them for a variety of reasons, right? And so when we're thinking about this and we're saying, okay, and you might be saying this already, Dr. Chris, why are women experiencing greater levels of pain, right? What is it? And, yes, there's the multifactorial component, but when we actually look deep in the literature, there's a ton of articles that talk about why women experience greater levels of pain. And essentially, it comes down to women tend to have greater pain sensitivity. They do not have a very good sense of reducing pain facilitation. So it's very, very high. And then the last piece of it is a reduced ability for pain inhibition. And so again, we see this with our chronic pelvic pain women, we see this with our chronic widespread pain patients. And so it can be a challenge to really find that happy medium for them. Now, one of the things that I do want to say is that we know it's costly, right? We know that women in particular, it's very expensive across the U.S. for this to be treated. But the other thing that we do know is that when we talk about chronic pain across the US, we say it's approximately 43% of US adults report chronic pain. And not only is it 43% of US adults, but approximately out of that, when we look at this, that's about 100 million people in the US, and most are women. And mostly what we're seeing out of those numbers is the musculoskeletal back and joint pain and multiple sites of pain. And I'm going to show you a slide in a minute, which talks about the prevalence of chronic pelvic pain and what actually we are seeing in the US. Because a lot of times practitioners will say to me, Dr. Chris, I don't see chronic pelvic pain in my practice. And you know what I'm going to say? You're missing it. So if you're one of those providers that are saying, I don't see it, I promise you're missing it, which means you need to be asking some questions that get to the root cause of pain for our patients. Now, I said to you a few minutes ago, emotion does have impact on perspectives of pain. This comes from the International Association for the Study of Pain, and I really do appreciate this definition when we're talking about pain, because we do know that pain is subjective, right? Two patients can come in, they could both have a disc herniation, and it looks very similar when we look at the orthopedic testing. It's very similar on the signs and symptoms they tell us, but yet their pain rating scale is very different, right? And they're perceiving pain in a much different way than each other, and that's okay. And we do know that it's subjective, but we also know that it's unpleasant, right? No one likes to live in pain. No one likes to be uncomfortable. And there's always, regardless of gender, an emotional component to it, because it impacts daily living. And, for lack of a better term, our patients will tell us what it gets in the way, right? It just does. And so we do need to be cognizant of this. And I want you to be thinking about the different types of pain that we see in practice, especially, and I'm going to hone in on the nociceptive pain for our pelvic pain patients, because that's truly where we live. And truly, when we're talking about chronic pelvic pain, we're talking about the combination of that somatic and visceral pain. And, I often say that sometimes that somatic and visceral pain is really hard to differentiate or dissect relative to the neuropathic pain, right? Because we all know as providers, you see non-nociceptive or neuropathic pain, it tends to be easier to recognize. And one of the things when we're looking at this, and we're looking at the different types of pain, somatic pain, just as a reminder, we do get that referral of pain from skin and bones and joints. It's transmitted along the sensory fibers. And one of the big things about visceral pain that I want to point out is we know that a lot of times that it's transmitted through sympathetic fibers. And the pain descriptors can be really challenging for visceral pain because it can mimic and manifest and look like a lot of different things. And we've all seen that in practice. But one of the big things that we recognize with this is that Again, it can be very poorly localized. It can be dull or crampy. We may see some other associated symptomatology related to this. So nausea, vomiting, sweating. Patients may have a real strong emotional reaction because of how unpleasant visceral pain can be. Now, again, when we're talking about pelvic pain, we can actually have somatic and visceral. And so again, we can be seeing both of those pieces together. Now, in addition to that, I said to you, neuropathic is really easy for us as a provider to see, right? Somebody comes in and they're talking about, burning or that lancinating pain. They talk about paresthesia. That is much easier to differentiate between than the other two. So, how do we define chronic pelvic pain in females, right? And this is really fascinating because we know when we're talking about the chronicity, there's time length, and traditionally when these individuals are diagnosed in their practitioner's offices, we say it's greater than 6 months of time. Okay, so if they come to you with a CPP diagnosis, they're looking at that time frame. They're looking at the pain to not be exclusive with menstruation, intercourse, or pregnancy. They're also looking at the component of it being intermittent or constant pain in the lower abdomen or pelvis. It's fairly localized when we look at this to the anatomic pelvis. We talk about anterior abdominal wall, lumbosacral back or buttocks. And, one of the other pieces are we may actually see that it has such significance that it causes functional disability or leads to medical care, right? And again, if we're seeing them in practice, it's leading to medical care. I mentioned to you a little bit ago that when it takes a long time for individuals to get the diagnosis for pelvic pain or for endometriosis. And when we're talking about chronic pelvic pain, there's an excellent article that actually talked about women that were reporting with chronic pelvic pain, found it very difficult to communicate with their general practitioner about the pain. And they felt that when they had conversations about this, they didn't think that the doctor quite understood what they were talking about. And they felt that when they left, that they got diagnoses that really didn't match what they had. And what they found in the study was an average of 73 different diagnoses were given to these cohorts of women that defined their pain, which really indicated there was nothing wrong with them. And which really missed the boat to help these individuals that probably had multifactorial chronic pelvic pain, right? And, here's the other thing. If we think about other providers when it comes to this, when we talk about our GYNs or we talk about our general care providers, they're very focused on viscera, right? They were taught to look to the organ and not so much look to the musculoskeletal component and looking at the soft tissue referral patterns, which is what we see as providers, not looking at the joint referral pattern, again, which is what we see as providers. So for us, and I always say this, we put our practice goggles on, it's really important to have those goggles on and be thinking about, okay, what's the musculoskeletal component that we need to be thinking about as a chiropractor practitioner, and also thinking about what are the other components relative to the visceral component, the neurological component. And I put some of my favorite diagnoses up here for you that we tend to see when we're talking about this, but really important. We mentioned endometriosis, adenomyosis, right? And so adenomyosis is when we see endometrial cells which grow into the wall of the uterus. And this can have a similar chronic pelvic pain-like feeling to these individuals. Talking about secondary dysmenorrhea, right? So dysmenorrhea, which the patient is experiencing, but they have another diagnosis like polycystic ovarian syndrome, like endometriosis, like pelvic congestion. So we have to be cognizant of those as well. And remember that regardless of the age, young females are never too young if they're menstruating for a primary or secondary dysmenorrhea diagnosis and or endometriosis and or chronic pelvic pain. Okay, so really, really important to be thinking about that. Some of the other things that we want to be thinking about as providers when we look at this is irritable bowel, making sure it is not a chronic constipation component, because we also know that chronic constipation can have a really big impact on pelvic floor, which is a conversation for another day. But that's an important piece. We also know that adhesions and fibroids can also have a component and relate back to pelvic floor, in addition to having impact on chronic pelvic pain. So important for us to have an eye on that. From a musculoskeletal perspective, we do have to be thinking about myofascial pain syndrome. We have to be thinking about referral of trigger points. We have to be thinking about referral of joint. All of that stuff does play a part and impact on how the patient is perceiving and reporting pain. I promised you a few minutes ago we would get to this. And if you're saying, and I said to you, if you're telling me, Dr. Chris, I don't see chronic pelvic pain, this is one of my favorite articles, because a lot of times if we're in person, I'll say to you, docs, how many of you see patients that have asthma, right? And a lot of patients will a lot of docs will raise their hand and say, yes, of course, I have patients that have asthma. And others I'll ask about chronic low back pain or chronic back pain, and practitioners say, yes, doc, I see chronic back pain. Of course, I'm a chiropractor. And when we look at the numbers relative to chronic back pain, in this study, there said about 41 out of 1,000 relative patients were reporting chronic back pain. 37 out of 1,000 were reporting being asthmatic, and 38 out of 1,000 reporting chronic pelvic pain. So again, if you're not seeing it, you're missing it. Big point on this next slide. 70% of patients don't seek medical treatment for chronic pelvic pain. When we talk about primary dysmenorrhea, think about that for a second. A lot of young girls grow up in a society where they believe cramping is normal, right? Heavy menstrual cycles are normal because their parents, mother, sister, cousin, friend have all experienced it. When we actually know as providers, it's not normal to experience that, right? So there's a bit of a component that's related to it. And sometimes it's an uncomfortable conversation to have. I often say it's easy to talk about menstrual cycle and not so easy to talk about individuals that have urinary leaking. That tends to be much harder to say, yep, I wet my pants versus I have a large amount of bleeding, right? So really different when we're having those conversations. One of the big things that are really important to us, I mentioned, and this is a whole list of different things we need to be thinking about in our histories, but the age of menarche, I talked about that very early on in our conversation today about, those that really have their first menstrual cycle before the age of 12, what that's a predictor for. And that's huge for us as providers. When we're talking about chronic pelvic pain, we do need to ask questions about the menstrual pattern, the cycle length, the duration, the amount of flow. Are they having any other symptomatology related to it? And really taking a really good history and determining where are they in their physiological journey. It's really hard for us, again, because if we're talking about the age of menstruation, we talk about how that has impact on their physiological journey. Perimenopause and menopause might not be when we think it's really truly supposed to happen. There are some individuals that go into early menopause, which is in early 40s. And so we may have patients that are exhibiting signs and symptoms of that very early on. And so it's really hard for us as providers to classify these women into this group. And so we do need to be thinking about that. The other thing that we do want to make sure of that we have a good understanding is, again, any past surgical history, right? We all know that when we're talking about past medical surgical history, that adhesions play a part in chronic pelvic pain. And especially, when we have patients that have had surgical procedure and it's exploratory, right? And every time they go in and they open up and they do the laparoscopic procedure, it increases their likelihood of having adhesions, which increases their likelihood of pain, right? And inflammation. And so it's a double-edged sword with those individuals. So again, what type, how long ago it was performed, and how it was performed. So I want to kind of now focus in a little bit more on the pelvis for a second. And I know a lot of you are looking at this thinking, okay, why are we looking at all of the different ligamentous structures posteriorly? And I always say when I give this lecture, which just so that we're all on the same page, this is usually a 12-hour lecture. So we're doing this in an hour of just a very high overview of a lot of these concepts. But when we look at this pelvic anatomy, one of the big things that I want you to be thinking about is we all have our routines, right? Our patient comes in, they lay on our table, and we touch them. And my routine was always, one hand on the thorax and one hand closer to the pelvis, usually around the sacrum. And thinking about all of the ligamentous structures that we actually have impact on around the sacrum is really important to us, right? We know that not only does joint and muscle have referral patterns, the literature actually tells us that each ligamentous structure can also be a source of referral pattern of pain, especially in our female patients. So one of the things that is important to us as providers is when we're treating the posterior aspect, is that we are thinking about not only moving the joint, whether you're adjusting and you call it subluxation, fixation, and whatever term you want to use, it's okay, but also be thinking about how are you treating, and if you're treating any of those ligamentous structures, whether it's cross friction massage, whether you're using an instrument or a tool, whether you're thinking about taping, all of those pieces have impact. Now, this is my favorite slide. And some of you might be thinking, oh my goodness, Dr. Chris, why would this ever be your favorite slide? And, one of the big things that I often talk about with women's health is that when we talk about this, traditionally, the broad ligament gets all the glory, right? Every single time we're talking about women's health, it's all about the broad ligament. Well, guess what we're forgetting about? Look at the uterosacral ligament, right? Somewhere, sometime, we all dissected this in chiropractic college, and there's that little ligament that directly attaches from the uterus to the sacrum. And so when we're talking about this, and I'm going to use my fake sacrum here for a second, but when we're thinking about this and we have an anterior sacrum, well, what's going on with the uterus, right? Well, it's in the way. So it's going to move along anterior with that sacrum. And then, oh, wait, where's the bladder? Well, it's going to move more anterior, right? And so anytime we've talked to patients about, and I'm not even getting into the neurological component, right? I'm just challenging you to think about the anatomical component. So if we have a sacrum that's anterior sacral base, or flexion and extension restriction, right? Depending upon what listing system you use, it's going to have direct impact on that uterus. How many times have you adjusted a patient and patients come in and told you just anecdotally, hey doc, you know what? I have a tilted uterus, right? The practitioner told me that, and they get adjusted by you treat them, and they come back and it's really weird. I went back and I no longer have a tilted uterus. Aha, right? So if we have an oblique axis where the sacrum is rotated or counter-rotated or counter-nutated or nutated unilaterally, what's going on with that uterus? It's going along for the ride, right? So I always say as providers, it's really important for us to not only treat the SI joint, but to treat the sacrum, and to be thinking about how we assess that sacrum for all ranges of motion, not just anterior, posterior, flexion, extension, but for some of the rotational pieces, the counter rotation, the nutation that we see with this, that really can have impact not only on the structure, but also pain. And you will find that a lot of patients, once you adjust the sacrum, will say, you know what, that feels so much better. It wasn't truly the SI joint that was really the pain generator. It was really that sacrum, right? And we know, again, looking at the biomechanics, that the sacrum has impact on L5, right? So if we adjust the sacrum, a lot of times we'll see a restriction, usually a rotational restriction, coupled with that sacral restriction, right? And a lot of times if we adjust the sacrum, that spinal restriction or subluxation will go away. And so as a provider, it's important for us to check and balance that. Some of the other things, thinking about the biomechanics of the pelvis, you've got a patient with chronic pelvic pain. We know that the forces from the lower extremities and the forces from the spine impact that pelvis. So they're getting forces from both directions. And so, again, thinking about, okay, if they're getting forces from both directions, what's going on in the top that we need to be considering, and what's coming up from the bottom? Are they wearing 5-inch heels every day? And that's changed their biomechanics of their pelvis. Are they, wearing flat, cheap flip-flops, right, without any arch support? And so we're watching to see a lot of change in their biomechanics when they're walking during gait. Are they carrying children all day long? Are they carrying heavy purses, right? There was an article a while back about, women carrying these ginormous purses, and what were they carrying? Like everything in those ginormous purses, right? And so, again, how does that have impact on spinal biomechanics and impact specifically on the pelvis? So this is just a visual. This I can't help. Okay, this is the chiropractic educator in me. When I was talking about the motion of the sacrum, right? And we know that the motion of the sacrum, it's very easy for us to not only feel, but sometimes see that anterior and posterior component of the sacrum. It's not always easy for us to see the unilateral rotation or the oblique axis that we might see as a provider. I always joke that sometime in our chiropractic education, someone told us that when we watched gait patterns of our patient, that their sacrum moved in a figure 8, right? And that we'd be able to see that during gait. Can't really see that. We don't ever really see that as providers, okay? But one of the things that we know is that when we actually palpate the sacrum and we're looking to see, subluxation, restriction, hypomobility, that we actually may find that it's restricted on a variety of planes. So important for us to consider. Now, we're at that point where practitioners will say to me, all right, Chris, so what do you do, right? You've got this chronic pelvic pain patient. They've come in, they've been everywhere. What's your plan of attack? And that's really important because, again, we do want to be looking at what are the root causes of this, and how can we help these patients. So thinking about gait assessment, right? It's really important to look at that pronation and supination. We just talked about the biomechanics from the bottom up. A lot of times what we don't remember or don't think about is when we're talking about pelvic pain, some of the reciprocal factors related to soft tissue components that can be impacted with that pronation and supination. Thinking about postural assessment as well. What is that lumbar lordosis looking like? Do they have a kyphosis, a thoracic kyphosis, which may be adding more pressure in some other regions and really altering the biomechanics of this patient? Do they have knee hyperextension? Do they have pelvic obliquity? That's huge, okay? So if you're seeing that pelvic obliquity, and what I mean by that is perhaps, and I'll give you an image, when we're doing a postural assessment, that you see a patient standing and their ASIS is more anterior on the right versus the left. And that pelvic obliquity will also be referred back to looking at the sacrum and making a decision about the sacrum. Because that sacrum, if it's rotated unilaterally, you'll see that with that standing posture. The other things to consider are functional testing. Active straight leg raise. This is not the straight leg raise test that you and I know to be the orthopedic test. This is actually a functional assessment. And this functional assessment, there's an image of the practitioner placing both of her hands on the ASIS of the patient. And as she's placing her hands on the ASIS of the patient, she's compressing down into the table. And what is she doing? Think about that for a second. She's providing stability. And as she's providing stability to that ASIS, the patient is then lifting one of their legs. And as they lift one of their legs, if the patient tells the provider, hey, doc, you know what, my pain has gone away. Aha, that tells us that stability helps. So what does that mean? It means that we need to be thinking about some component of hypermobility. Okay, and that's important because that can contribute to chronic pelvic pain. The other piece is after they've done both sides and they've compressed on the ASIS, you can move down to the pube tube. Now, I always say be very careful, right? Have your patient protect themselves, doctor protect over themselves to not create anything inappropriate. Anterior to posterior into the table. Same thing, they lift one leg, they lift the other leg, and practitioners assessing for pain. Pain goes away, then we're thinking again about lower SI joint hypermobility, okay? You do have to rule out any hip pathology with this assessment. Also very good with ruling out hip pathology for chronic pelvic pain, because we do know that labrum can actually refer and look like chronic pelvic pain. And then also hip extension, okay? Looking at that hip extension testing. Fascia, right? Pain generator that we have to be cognizant of is thinking about that lumbothoracic, thoracolumbar fascia, okay? Thoracolumbar fascia wraps around and attaches on to transverse abdominis. And so a lot of times if our patients are having muscular imbalances and the thoracolumbar fascia is not treated, whether you do cross-friction massage, whether you do instrument-assisted technique, whatever it might be, that will help to assist with, again, working on some of the muscular imbalance, but then also some of the soft tissue referral and pain generator that fascia might be in this piece. Other things to be thinking about, especially in our chronic pain patients with referral patterns of pain relative to muscle. So iliopsoas, we know that can be a large generator if there is a trigger point in there, iliacus, multifidi, QL, abdominals, and my absolute favorite is pyramidalis. And so if you've forgotten where pyramidalis is located, right, it comes off of the pube tube and attaches onto the linea alba. And if you compress in there, a lot of times in the chronic pelvic pain patients, you'll find a ginormous trigger point. And a lot of times it'll be very, very sore. It'll be very, very painful for these patients. But sometimes it's truly a component of the pain generator for them. And one of the other big things, we talked about adjusting the sacrum, and of course you need to be looking at the SI joint and the lower lumbar spine, but then also looking at the pube tube, because we actually do know that sometimes, and again, this can be restricted or subluxated superior to inferior. And sometimes when it's in that vector of restriction, that it has impact and is also a pain generator. Okay, so also looking there as well. The other place we need to be cognizant of is our TL junction. Okay, Main syndrome, TL junction syndrome, a lot of different terminology, sometimes also called cluneal nerve syndrome. And we know that the TL junction can actually be another component of chronic pelvic pain, as in females and males, it refers three places. It can refer to the femoroacetabular joint. It can refer posteriorly to the SI joint. And anteriorly, it can refer to the lower pelvis. So it can mimic like uterus, ovary, bladder pain in women. In males, it refers and can look like testicular pain. Okay. So again, really weird referral patterns of pain, but can be a component. So as for looking low in the pelvis for all of these pieces, we need to go back up to that TL junction. And again, don't forget about that looking at the fascia from the thoracolumbar region. Now, again, just a reminder that the sacroiliac joint has referral patterns too. So if there's a restriction or hypomobility subluxation, that SI joint can actually be a cause of some of that referral. Remember that when we look at this as well and we see, some pain posteriorly, again, it can look like glutes, it can look like thigh, it can look like a dermatomal pattern, but anteriorly, it can look like groin and anterior thigh. And sometimes women with polycystic ovarian syndrome or chronic pelvic pain will tell you, like, I have this weird groin pain, I feel thigh pain at times, and it feels very inflamed to them. And so again, really, truly trying to dissect those pieces. This is just a reminder for me to make sure that we talked about some of those visceral referral patterns of pain like we just did. And again, it's important as the provider to make sure you're asking those questions and ruling out some of those visceral components. So I want to shift for a second, because dysmenorrhea can also be a very, very strong component of chronic pelvic pain for women of all ages, whether it's primary or secondary. And I said to you earlier that a lot of women think dysmenorrhea is normal because people experience it. So it's a normal condition. And one of the things that I want you to be thinking about is not just adjusting your patient, but why, right? Why do women experience dysmenorrhea? Why do they experience some of the chronicities of pelvic pain if it's not a referral pattern from soft tissue? But one of the big things that we do see with women is when they make poor dietary choices or have high stress levels, that can trigger the chronic inflammation component, right? EDCs are endocrine disrupting chemicals. So we find those in our toothpaste, our face washes, makeup, looking at any shampoos, okay? Any of those individual things are inflammatory triggers, and they can mimic higher levels of estrogen. And anytime we've gotten an inflammatory trigger that goes into that chronic inflammation bucket, immediately we know that our females are building thicker uterine lining. And if they're building that thicker uterine lining, it's because they have high levels of circulating estrogen. Okay. And we know that that feeds back into the chronic inflammatory process, which can have impact on blood sugar, thyroid, sex hormones, immunity, a whole bunch of things. Okay. But the thicker uterine lining leads directly to more cramping and heavier bleeding. So, as a provider, when we're hearing this can be a component that our patients are reporting. We know that the literature tells us that if females take 200 milligrams minimum of ginger during the first 3 days of their menstrual cycle, it will help with the chronic inflammation process and the amount of bleeding and cramping a female will experience. Now, docs always ask me, what if they juice it? What if they eat it? However you ingest it, it's okay, but just make sure you have 200 milligrams because that's the minimum, okay? And again, your patients will have very good response to it. The other thing is adjusting, okay? I mentioned to you looking at that sacral component. We did a study not too long ago because we were seeing this in practice, and I kept saying, okay, so we get these dysmenorrhea patients in, we treat them, but what's really working? And we're adjusting them. Some of them are getting massage, some of them are getting acupuncture, some of them were getting a modality like heat or IFC. And so what was it? And so we did a study and we just wanted to see, what if we just adjusted the patient and what would happen? And so we took individuals that had primary dysmenorrhea, obviously looked at their restriction, subluxation, hypomobility, and determined what the lumbosacral junction looked like, whether it was a bilateral or unilateral flexion extension restriction, really looking at that sacral motion. And what we found is when we treated these individuals 6 times over 2 months, there was a significant decrease in their abdomen and low back pain symptomatology. And that was just with manipulation. So I say, if you don't do anything else and you adjust, then you're going to have impact. But if you add in supplementation by decreasing that inflammation, if you look at a variety of other things, you will have impact. Now, I know we're close on time, and I just want to talk about Elaine for just a second. She was one of those patients, and she came to me. She was 32 years old. She'd been living with anterior pelvic pain in her lower left quadrant for quite some time. Again, her onset was 20 years old, so she's like 12 years with this anterior pelvic pain, had been everywhere, hadn't gotten really good resolution, had multiple surgeries, was taking medications, and really was really stressed because she really truly wasn't getting a good diagnosis. They determined her first surgical procedure, she had small amounts of endometriosis, but she went back for a second procedure 6 months later because she was still having the pain and she never got better. Still was having low back pain, pelvic pain. And, again, what did they find? Some more adhesions. Well, obviously, the more times they kept going back in, the more they were contributing to this. So essentially, by the time she came to see me and, we did her exam, there was nothing very exciting on her postural exam. Her range of motion was painful. She had a decrease in the lumbar spine. looking at any of her orthopedic assessment, it was really focused in on positive orthopedic assessment in the SI joint region. I did muscle reflex sensory just to make sure we weren't missing anything. And truly, she had SI joint challenges as well as TL junction. So what did I do? I adjusted her pelvis, I adjusted her lumbar spine, the TL junction. She did not love me for doing ART to the psoas, but we did it. Really looked at trigger point work, looked at that pyramidalis I talked to you about. Turns out she had actually an anatomic leg length from surgery from when she was a child. And we worked on decreasing the inequality and really tried to balance out her pelvis from that leg length inequality that was anatomical. And she responded to care beautifully. So for the first time in 12 years, she did not have pelvic pain after 5 treatments. And so when we look at this as providers, this is a big cue that other practitioners miss this, right? I started off by talking about how we see women in our practices, how they sometimes come to us with all of these different components relative to pain, and they're not really truly given, a good diagnosis that gets to the bottom of it. So as practitioners, it's really important we get to that multifactorial piece. So I hope today, as we started off and I said to you, challenge you to think about your female patients differently, or provided you with something new to take back into practice, or simply reinforce something you currently do or have put away in that toolkit, and that you truly can help these female patients move beyond that pain that they're experiencing. And so one last piece is I really truly hope today, because somebody once told me that if I wanted to be incredible, you must be credible. And so continue on your journey of being credible to help your female patients in practice and give them the absolute best patient-centered care that you possibly can. So thank you so much for your time. Christy, I don't know, are there any questions?
No questions, but what an amazing presentation. I love listening to you talk.
Thank you.
I always learn so much from Dr. Chris. If you are interested, there is still time to register for the Women's Health Symposium. You can do it virtually or in person, and registration, I believe, ends on Friday, correct?
Yes, that's correct.
So I'm going to go ahead and post the link here in the box, where you would get to hear from Dr. Chris, as well as Dr. Cindy Howard, who has also been a webinar presenter before. Dr. Chris has also provided her email address in case you're like me and you think of questions like 2 hours after a presentation or 2 days after a presentation. I never think of them while I'm watching the presentation, so that you can reach out to her. She's a tremendous resource. And really, like, this is just like the tip of the iceberg of what she teaches.
It is. This is a 30,000 foot view today.
It really is. So if you have the opportunity to hear her speak virtually or in person, I strongly recommend that you definitely sign up and take a front row seat, because you will get something out of it every single time. Lucky for me, I get to travel all over the country, so I get that opportunity pretty regularly. So I want to thank everyone. I posted the link for next week's webinar. We have we have Dawn Rasmussen, not a doctor, with Quartermaster Tax Pro, who's going to be joining us to talk about the $25.5 billion in provider relief funds that are available. He's also going to be touching on how to master 2020 HRSA audits. So the link is there for you to go ahead and register. That's next Tuesday at 2:15 p.m. Eastern time. The following week, we're going to have Dr. Mario Fuchineri. He's going to be talking to us about the ABN update, which go into effect before that webinar, but we couldn't squeeze them in any sooner than that. So lots of updates coming from the state and federal government. The following week, we're going to have a webinar on November 2nd with Dr. Scott Munsterman, and he's going to be talking about all the new OSHA updates that have just been released. And I, for one, am beyond grateful for all the people who read the 3,000 pages of insanity just so they can narrow it down and say, this is what applies to us and this is how we do it and do it right. So make sure you register for those. You can also go to ChiroHealthUSA.com webinars to take a look at the calendar and all of the upcoming webinars that are coming to you. We have a lot of great topics, new speakers that are going to be presenting this year, and the 2022 schedule will be released soon. Dr. Chris, thank you so much. I'm super sad that I'm not going to be with y'all at the Women's Health Symposium, but give Cindy a hug
next year.
That's right. I'm just going to follow y'all around the country and just have fun.
That's okay. You can do this.
So everybody have an amazing rest of your day and a fabulous week. And I will see y'all next Tuesday, same time, same place. Go be awesome. Bye, y'all.